Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Laboratory here at California State University, Sacramento. Today we're going to be talking about the structure, function, and pathology of the median nerve. Its origin is the brachial plexus, specifically the merging of the lateral root of the lateral cord receiving C6, C7 fibers, and the medial root from the medial cord receiving C8 and T1 fibers. So the median nerve is a C6 to T1 mixed peripheral nerve. Mixed meaning it contains both motor and sensory nerve fibers. So I want to first give a summary of each. So let's start with the summary of the motor function of the median nerve. So these are the muscles. So when you think of the median nerve, you have muscles in the anterior compartment of the forearm and the lateral hand. So there's 8 muscles in the anterior compartment of the forearm, 4 superficial, 1 in the intermediate layer, and 3 deep. The median nerve innervates 6.5 of those 8, so almost all of them except for the medial 1.5 muscles. So the way you remember the 4 superficial muscles is put your web space into your medial epicondyle. That reminds you that's the origin of these 4 superficial muscles. And the fingers running down the forearm represent the forearm muscle. The little finger is going down the medial side, that's the flexor carpi ulnaris. That is the only superficial muscle that is not median nerve. It's ulnar nerve. It's going to go down to the base of the 5th metacarpal and the pisiform and flex the wrist and ulnarly deviate. So that will be spared with a median nerve pathology. The next 3 are all median nerve of the superficials. The ring finger represents the palmaris longus. It's absent in about 10 to 15% of the population. Its tendon's right pretty much in the center of the wrist. So if you don't have one there, then you may not have one. And then it's going to go into the palmar aponeurosis and tense the fascia of the palm and also can help with flexion of the wrist. It's primarily going to be innervated by C7 and C8 as well as some C6. Then the middle finger is represented by the flexor carpi radialis, and its tendon is just lateral to the palmaris longus. It's going to receive C6, C7, primarily C7 nerve fibers. It's going to come down and insert into the base of the 2nd and 3rd metacarpals, crosses the wrist anteriorly and laterally, so it flexes and radially deviates the wrist. Flexion and radial deviation. So that's the flexor digitorum, or flexor carpi radialis. And then the last finger, which is the index finger here, now we'll let the others disappear for a second. This is the pronator teres. So it actually has 2 heads, one at the medial epicondyle, like we said, and 1 additional head at the coronoid process of the ulna. And it's going to go about 1/3 of the way down the radius and insert into the radius. So because it's on the radius, it can pronate, force vector pulling in this direction. Part of the force going this way is going in the medial direction, so that will pull the radius over the ulna. So it's your most powerful pronator of the forearm. So those are the 3 superficial muscles innervated by the median nerve. Again, remember the 4th one is ulnar nerve, the flexor carpi ulnaris. And then you also have 1 muscle in the intermediate layer, and that's the flexor digitorum superficialis. That also has 2 heads, a humeral ulnar head on the medial epicondyle and the coronoid process of the ulna, and a radial head. And then it's going to come down under the transverse carpal ligament, known as the flexor retinaculum, through the carpal tunnel, and the tendons are going to insert into the base of the middle phalanx of the lesser 4 fingers here. So it can flex the proximal interphalangeal joint, known as PIP. One way you can test for it is doing this maneuver where you stabilize the 3 of the lesser fingers, use the middle finger, and then go ahead and flex PIP, like you see me doing, while you keep dip nice and relaxed. So this is the function of the superficialis. You want to make sure you keep this distal interphalangeal dip from flexing, because that's the action of the flexor digitorum profundus. So that's how you can, another way you can do it is you can stabilize the proximal phalanx and then flex PIP up like this way. And actually you can feel the tendon right in the middle of your hand when you do that. So those are the four muscles, 3 in the superficial layer and 1 in the intermediate layer. That leaves 2.5 more because it innervates 6.5 of the 8 muscles. So the remaining 2.5 muscles are the deep muscles, and those are going to be the flexor pollicis longus. So it originates in the middle third on the radius, and it's going to come down again under the transverse carpal ligament in the carpal tunnel, deviate, follow the thumb, and insert into the base of the distal phalanx. So it's in good position to flex the IP joint like this. So you stabilize the proximal phalanx and have them bend the distal phalanx. So you're flexing the IP joint, and that's an intact flexor pollicis longus. The second deep muscle is the flexor digitorum profundus, but the median nerve only innervates half of it. So that's why we say it innervates 6.5 of the 8 muscles in the anterior compartment. So it innervates the half that controls the index and the middle finger right here, the lateral half. And this muscle originates on the proximal ulna and the interosseous membrane. It again is going to go down through the carpal tunnel, under the flexor retinaculum, and it's going to go under the superficialis tendons until it gets into the fingers, and then it's going to come up through a slit in the superficialis tendons and insert into the base of the distal phalanx. So it flexes dip, the distal interphalangeal joint. The way you assess for it is you stabilize the middle phalanx and have them bend the distal phalanx, so flexing dip like this. This shows an intact flexor digitorum profundus. So only the 2 lateral fingers, the 2 medial fingers of the profundus is ulnar nerve. So those are your 6.5 muscles, and collectively it's helpful to know these muscles are called the flexor pronator mass. It's descriptive of what they do. They flex the wrist, they flex the fingers, they flex the thumb, and they pronate the forearm. So if you have an injury to the median nerve, a high median nerve injury, before these muscles get innervated, so that's going to be an injury up in the arm, and we'll talk about that next, it could affect all the flexor pronator mass muscles potentially, and then that's when you're going to have weakness in wrist, finger, and thumb flexion and forearm pronation. In addition to the 6.5 muscles in the anterior compartment, it's also going to travel under the carpal tunnel, and it's going to innervate the 3 muscles in the thenar region that control the thumb, actually only 2.5 of the muscles, because it only gets the superficial part of one of them, and the lateral 2 lumbricals. So let's talk about those briefly. You have 3 muscles in the thenar region. They all originate on the lateral flexor retinaculum and the lateral carpus, which is your trapezium and your scaphoid. Then the most radial side, you have the abductor pollicis brevis, which is going to abduct the thumb. Abduction of the thumb is bringing the thumb up this way, but it only does it at the metacarpal phalangeal joint, which is this joint right here. And then just on the ulnar side of that, right in here, is the flexor pollicis brevis. So this is the one that has 2 heads, and it's only going to innervate the superficial head. The deep head is innervated by the ulnar nerve. So that's why we say 2.5 muscles in this area. It's going to come up and insert into, again, the base of the proximal phalanx. So it's in good position to flex the thumb or bring the thumb across the hand, but again, only at the metacarpal phalangeal joint. It doesn't cross the interphalangeal joint here. That's the flexor pollicis longus that we talked about. So it's only going to flex right here at the metacarpal phalangeal joint. So that's the flexor pollicis brevis. And the last one is the opponens pollicis, which inserts into the most of the length of the first metacarpal in here, and it's going to help oppose the thumb over to the little finger or any of the fingers for that matter. So that's opposition. So if you have an injury to the median nerve, especially a high injury or even one in the forearm, then it can potentially affect the function of the thumb from these 3 muscles. Your thumb is your most important digit for hand function. So if you've lost the ability to flex and abduct and oppose the thumb, potentially your hand is going to be, at least to some degree, dysfunctional. And then the last 2 muscles are the lateral 2 lumbricals. Okay, these are worm-like muscles that originate on the tendons of the flexor digitorum profundus that we talked about recently, and they're going to come up and insert into the oblique fibers of the dorsal hood, which is part of the extensor mechanism, and the base of the proximal phalanx. Because they're coming down this way on the palmar surface, they produce a torque that flexes the metacarpal phalangeal joint. They're coming below, as you see here. But because there's tension in the oblique fibers of the dorsal hood, that tension is transferred up to the extensor mechanism through the central band, which comes through the dorsal part of the proximal phalanx, inserts into the base of the middle phalanx, and the lateral bands that come off of it, and the terminal tendon that inserts into the base of the distal phalanx. So tension there can produce a torque that will extend pip and dip. So therefore, the function of the lumbricals is to flex the metacarpal phalangeal joint and extend pip and dip. Basically assume this lumbrical grip. It's called a lumbrical grip. It's commonly used by clinicians in manual therapy, such as proprioceptive neuromuscular facilitation, PNF. And this is the sign for it. So if you have a dysfunction of the median nerve, when you ask them to do a lumbrical grip like this, these two fingers may not be able to do it very well compared to the other two fingers, because the two medial fingers over here, these are ulnar nerve, where the two laterals are innervated by the median nerve. So that's a summary of the motor function. Now let's do a summary of the sensory function of the median nerve. It's really quite simple. It innervates the skin, supplies the skin on the lateral, 3.5 fingers, and hand. Primarily on the palmar surface, but it also wraps back around on the dorsal surface of those same 3.5 lateral fingers, but only the distal phalanx, so the nail beds. So we're talking about the thumb, the index, the middle finger, and half of the ring finger, and the lateral hand, the thenar region, and the central palm as well. You have a higher density of sensory receptors in the pads of the fingers. So if you have an injury to the median nerve, then you're more likely to experience numbness, pins and needles, tingling sensations more in the pads than you will other parts of the fingers and the hand. But potentially you could experience it everywhere if you had a bad enough injury. So that's a summary of the sensory function. So that gives a nice overview of both the motor and sensory function of the median nerve. In this next segment, we're going to now trace the median nerve as it travels down the arm, the motor and sensory branches that come off of it, where they come off, the muscles they supply, the function of those muscles, motor and sensory deficits that can occur from an injury, specific places that the nerve can be impinged or injured as it runs down the arm, as well as signs and symptoms of median nerve injury. So we're starting at the beginning. It's going to run down the arm, and it's going to run down the medial aspect of the arm, and it's going to go lateral to the axillary artery, which is going to become the brachial artery. And then it's going to switch as it gets into the distal arm. And to the distal arm, this is where you can have your first impingement type problem, as the nerve is going to run through an osteofibrous tunnel formed by the medial epicondyle, the medial supracondylar ridge, and the ligament of Struthers that connects those two structures. So it runs through that tunnel, fractures of the medial epicondyle, supracondylar fractures, trauma in this area, that can all cause an injury to the median nerve. This is referred to as a high median nerve injury. If you have it high, it's going to affect everything distal. Everything proximal to it, motor and sensory, is intact. But there is nothing proximal to this injury because all the function, motor and sensory function of the median nerve, is distal to the arm. It's in the forearm and in the hand. So it basically can affect all the actions we talked about. The flexor pronator mass, so you could have weak wrist flexion, finger and thumb flexion, a weak grip, a weak tip-to-tip pinch like this, hand dysfunction. All those can occur with a high median nerve injury, as well as abnormal sensation in the lateral 3.5 fingers and hand. Okay, now as we continue with the nerve, it's going to come out of the osteofibrous tunnel and enter the medial cubital fossa, which is in this area right here, so at the level of the elbow. Just distal to the elbow, right in this cubital medial fossa, it's going to send off 4 motor branches to the nerves that are in the superficial compartment, so your palmaris longus, your flexor carpi radialis, and your pronator teres. Those are your 3 superficial muscles, and the one in intermediate compartment, which is your flexor digitorum superficialis. So those are sent off very early. Then it potentially could be impinged and injured again as it travels down. Right in this area, you have the two heads of the flexor digitorum superficialis. That fibrous arch is formed. It could potentially be impinged there, or as it travels under the bicipital aponeurosis, you get an abnormal thickening of the aponeurosis. Potentially that could injure the nerve if it's traveling in this medial cubital fossa. But more likely, it's going to be injured as it travels between the two heads of the pronator teres. So remember, this represents the pronator teres. It has two heads, medial epicondyle and the coronoid process, and as it travels between those two heads, it can be impinged. Now, if it is impinged, that's called pronator teres syndrome. Now, the four muscles I just talked about, 3 superficial, 1 intermediate, they've already been innervated. So that will spare the functions that those muscles do. And so you still have some wrist and finger flexion. You won't lose that. You could still lose some, but you won't lose it from those muscles. What will you lose? You're going to lose potentially everything distal to the lesion. So what's distal, if it's being compressed between the two heads of the pronator teres, the only thing left that it hasn't innervated are the 2.5 deep muscles in the forearm and the muscles in the hand. So the 3 thenar muscles and the lateral 2 lumbricals. The motor-wise, those can be affected. So again, the 3 deep muscles, it's actually going to only innervate 2.5 of them, half, the lateral half of the flexor digitorum profundus. So that again is going to flex the distal interphalangeal joint. And then the flexor pollicis longus flexes the interphalangeal joint. So that allows you to basically do this. And then also the pronator quadratus. That's the final deep muscle. And that's going to go from the radius to the ulna in this direction. It's just a small muscle that helps pronate the forearm at the distal radio-ulnar joint. Okay, so this would be a sign for pronator teres syndrome, but not just this, it could also, if it affects the median nerve, which is a mixed nerve, sensory and motor, it could also affect the muscles in the thenar, so you have dysfunctional use of the thumb, ability to flex, abduct, and oppose the thumb, and the lateral 2 lumbricals, the ability to flex the metacarpal phalangeal joint and extend pip and dip in those 2 fingers. And sensory-wise, abnormal sensation in the lateral 3.5 fingers, and the hand can be affected. That's pronator teres syndrome. Interestingly enough, a branch comes off the median nerve as it goes through the 2 heads called the anterior neurosseous branch. It can also be impinged as it's going through the 2 heads of the pronator teres. This is a C8-T1 motor nerve. So all the muscles it supplies is going to be in that C8-T1 levels, and the muscles it supplies are the 2.5 deep muscles we just talked about. Those are the muscles that do the OK sign, just like this. So if you have an injury to the anterior neurosseous nerve, you have them do the OK sign, which you pronate, and then you flex the IP and you flex the dip. And if they can't do that, that's a positive sign for anterior neurosseous syndrome. And it's a motor nerve only, so there's no sensory. It just affects those 3 muscles. Then the median nerve is going to continue down the forearm between the flexor digitorum superficialis and the profundus. It's going to deviate laterally and go between the palmaris longus and flexor carpi radialis tendons. And a few centimeters before the wrist, the palmar-cutaneous branch is going to come off. It's going to travel superiorly to the flexor retinaculum, right in here, and it's going to innervate the skin in the central and lateral palm. This is important clinically because it goes superior to the flexor retinaculum or the transverse carpal ligament. So it doesn't go through the carpal tunnel. So in carpal tunnel syndrome, the central palm and the lateral palm is spared. You don't have abnormal sensation there. You just have it in the lateral 3.5 fingers in carpal tunnel. Then the median nerve is going to continue through the carpal tunnel, and along with the 9 extrinsic tendons and their synovial sheaths. So remember, you have 4 tendons from the flexor digitorum superficialis, 4 more from the profundus, and then 1 from the flexor pollicis longus. So they travel through synovial sheaths. If you have repetitive use of your hands, your fingers, your thumb, typing all day long, that could overuse those muscles. You can get a tenosynovitis, an inflammation, a swelling. That puts additional pressure on the median nerve, and that can cause carpal tunnel syndrome, causing motor and sensory distal to the lesion. Now, distal to the lesion, all the muscles in the anterior compartment of the forearm have already been innervated by now. So you're going to have good function with these muscles. Where you're not going to have good function potentially in carpal tunnel are the muscles that are distal, which are your three thenar muscles, so flexing, abducting, opposing the thumb, and the two lumbricals. That's where you get motor deficits and sensory deficits in the lateral 3.5 fingers. So overuse, especially if they're flexing and extending their wrist a lot, or they have bad position, that can decrease the volume in the carpal tunnel. So a test for it is actually a Phalen's test, where you go hyperflexion like this up to 60 seconds, and that compresses the contents, including the median nerve, in the tunnel. And if you have abnormal sensation in those lateral 3 fingers, that's a positive sign for carpal tunnel syndrome. The earlier in the 60 seconds you have it, the worse the condition. The later, the less severe the carpal tunnel. Or you could do a reverse Phalen's, kind of a prayer position where you hyperextend. That can also compress the contents. Either one of those you can do. So because a lot of flexion and extension potentially could irritate the nerve in the carpal tunnel, a lot of times we splint the wrist, we keep it in neutral, especially when they're working all day long or when they're sleeping, where the wrist can do different things. So that would be one of the ways to get carpal tunnel syndrome. There's other ways, falling on an outstretched hand and dislocating the lunate bone. That can decrease the volume and increase the pressure in the tunnel. Also an abnormal thick transverse carpal ligament. That can put more pressure down as well. That can all produce carpal tunnel. Now, distal to the injury is where you're going to get the effects. So in addition to thumb dysfunction, and thus hand dysfunction, since your thumb's your most important digit, you can also, it can affect the lateral 2 lumbricals, but you're not going to see any atrophy in the lumbricals. You're going to see it in the thenar region. You can see how plush this is here. So if you have a bad enough injury over a prolonged period of time, the thenar muscles can atrophy and flatten out, and now you have what's called ape hand deformity. A flat hand resembles an ape's hand. So that's ape hand deformity, positive sign for carpal tunnel syndrome. Some other signs you can do is you can tap over the median nerve. If it's irritated in the carpal tunnel, you can just tap just lateral to the central wrist over the flexor retinaculum. A little bit of compression would irritate it even more, and that could send abnormal sensation down into the lateral 3.5 fingers. That's the Tinel sign for carpal tunnel that you can also use in addition to Phalen's test. Now remember, the finger flexors from the superficialis and profundus are intact in a low nerve lesion, but in a high nerve lesion, it can affect everything. So one of the tests you can do in a high nerve lesion is you can have the patient hold their hand like this and tell them to make a fist. When they go to make a fist, only these medial 2 fingers go down, because these medial 2 fingers are innervated by the ulnar nerve, the flexor digitorum profundus. The medial half is ulnar nerves. So it can pull those fingers down. But these 3 fingers, you get the superficialis and the profundus and the flexor pollicis longus. If they're all completely paralyzed, you won't be able to move. That's called the hand of benediction sign. So this is more you're likely to see in a high nerve lesion in the arm, but not with a low nerve lesion at the wrist in carpal tunnel. Now, if we finish this, you follow the nerve. The median nerve is going to go through the carpal tunnel, and then it's going to have 2 branches. One's going to be the recurrent branch, motor branch only, sometimes called the thenar branch. It's going to loop around the lateral distal flexor retinaculum, become somewhat superficial at that point, and then go deep into the thenar muscles, those 3 muscles. Actually, it's only 2.5 of the muscles. It's only going to get the superficial part of the flexor pollicis brevis. So that can cause atrophy of the muscles and dysfunction, like we talked about. And then the other branch, other than that, is the lateral and medial palmar digital branches. They're both motor and sensory. The motor function, the lateral branch innervates the first lumbrical on the index finger. The medial branch innervates the second lumbrical of the middle finger. So again, that produces that flexion of the MCP joint and extension of pip and dep that we talked about. And then the remaining of the palmar digital branches are sensory. So they're going to innervate the lateral 3.5 fingers. Remember, the central palm and the lateral palm have already been innervated by the palmar cutaneous nerve up here. So it's spared in carpal tunnel syndrome, like we said. So that's a summary of the structure, function, and pathology of the median nerve.